The League believes that a basic level of quality health care at an affordable cost should be available to all U.S. residents. Every U.S. resident should have access to a basic level of care that includes the prevention of disease, health promotion and education, primary care, including prenatal and reproductive health, acute care, long-term care, and mental health care. The League favors a national health insurance plan financed through general taxes in place of individual insurance premiums, which is commonly known as the single-payer approach. The League believes that the ability of the patient to pay for services should not be a consideration in allocation of healthcare resources. At the last convention in 2016, a position on behavioral health was adopted by concurrence. The key points are that all people need access to affordable, quality, inpatient and outpatient behavioral health care, including needed medications and supportive services, and that behavioral health care must be integrated with and achieve parity with physical health care. In 2010, after 2 decades of League work to ensure access to affordable, quality health care for all Americans and to protect patients' rights, the Affordable Care Act, or the ACA, was signed into law. The League does support the implementation of the ACA and remains vigilant in the light of the current efforts to repeal or diminish the law in Congress and in the courts. According to a 2017 Kaiser Women's Health Survey, 7 years after the passage of the ACA in 2010, 9 in 10 women now have health insurance coverage, more than ever before. In addition, the majority of women who use contraception have full coverage without cost sharing under the ACA's preventative services requirement. But we still have a long way to go to achieve universal health care for all U.S. residents. International human rights law recognizes one's fundamental right to health care, yet the U.S. stands alone among developed countries with millions left uninsured. In our complicated and fragmented healthcare system, large gaps in health equity still persist by income, by education, race, ethnicity, geography, gender identity, and physical abilities, among other factors. It is time to embrace the fact that healthcare is not a privilege for the few in America, but a human right for all. It is time to implement a socially just system of care in the form of a national improved Medicare for all. And make no mistake, these are trying times for advocates of universal care. In the last year alone, we have faced multiple threats. We saw the individual mandate penalty repealed, which the CBO predicts will cause 13 million fewer Americans to be insured by 2027. We've seen states gain the right to, the power to impose work requirements on Medicaid enrollees. In Kentucky alone, 95,000 Medicaid enrollees are expected to lose coverage within 5 years. There are near weekly assaults on our reproductive freedoms in many states. Funding for the Children's Health Insurance Program, CHIP, on which almost 9 million low-income children depend, was in serious jeopardy, as were the federally qualified health centers, those safety net providers of comprehensive primary and preventative care. And then recently in February, 20 states attorneys general, led by Texas, filed a suit to have the entire ACA declared unconstitutional, which includes coverage for pre-existing conditions. An Urban Institute 2018 analysis shows that if the entire ACA were eliminated, the number of uninsured people will increase by 17 million next year in 2019. And 52 million adults are expected right now to have pre-existing health conditions that would likely become uninsurable if that were to happen. So in face of all these challenges, it has never been more important for advocates of single-payer healthcare to stand up and make ourselves heard. To tell us more about improved Medicare for all and what actions we can take, I'm honored to present our invited speaker, Dr. Claudia Fegan. And Dr. Fegan is the Chief Medical Officer for the Cook County Health and Hospital System and John H. Schroeder Hospital of Cook County. She's also president of the Chicago-based Health and Medicine Policy Research Group. She received her undergraduate degree from Fisk University and her medical degree from the University of Illinois College of Medicine. She is a fellow of the American College of Physicians, certified in health quality and management, and a diplomate of the American Board of Quality Assurance and Utilization Review Physicians. She is also a national coordinator for Physicians for a National Health Program. In her current and past leadership roles in PNHP, she appeared on national television and radio programs and has testified before congressional committees on a wide range of healthcare issues. She has lectured extensively in both the medical community and audiences on healthcare reform in the U.S. and Canada. And she's co-author of the book Universal Healthcare, What the United States Can Learn from the Canadian Experience, and a contributor to 10 Excellent Reasons for National Healthcare. So we'll have Dr. Fegan speak, and then we will have time for a Q&A at the end.
Thank you. And thank you for getting up and coming to hear me this morning. I want to make the point that a lack of access to health care drives injustice and inequity, because people don't always connect that. So I want to ask a question. How many people in the room were born in this country? Okay, everybody. And so how many, were both of your parents born in this country? And both your grandparents born in this country? So, my parents were not born in this country. So let me ask you another question, because I want you to think about this. How many people in this room have health insurance? Very good. Now, how many people in this room think they have good health insurance? All right. Those people who think they have good health insurance, how many of you can tell me, if you walk outside, cross Michigan Avenue, and get smacked by a bus, how many physical therapy visits are you entitled to? Who can tell me? All right, most of you cannot. My point is, you don't know anything about your health insurance until you have to use it. So, I'm the chief medical officer for a health system. And I think I have good health insurance. Until my husband got leukemia. And the first bill that we got for his first hospitalization was $200,000. The second bill was $180,000. And the third bill was $150,000. Getting better. In his last year of life, my husband was hospitalized 8 times. And my responsibility for his health insurance is 20%. Can you understand how not having health insurance might affect the decisions that you make in life? So, I had a patient I admitted to the hospital a few years ago. She was in her 50s. She worked as an aide in a nursing home. She lived alone. And she had been having trouble swallowing for several months. And she'd been losing weight. But she didn't choose to come to the doctor until she felt like this was really a serious problem. So, she had no health insurance because what many of you may know, but some of you may not, is that even with the Affordable Care Act requiring employers, large employers, to provide health insurance, it's capped based on the number of hours. And many employers went to a plan where they would have more employees who worked fewer hours, and it was cheaper than providing insurance. So I had to tell this lady, after we worked her up, that she had inoperable esophageal cancer. And that we were going to put in a feeding tube because it wasn't safe for her to swallow. And we were going to be able to treat her with radiation. And that the radiation was not going to cure her, but that it would make it possible for her to swallow. And it would ease her discomfort and give her a chance to put her affairs in order. And she was asking me, how soon after we put in the feeding tube could she go home? And could her radiation treatment, which she understood were going to be every day, could they be scheduled for late in the day, like 4 o'clock? So that she could go to work and come after work. So I'm telling her she has a life-limiting illness. And she's trying to help me understand that if she can't work, she can't pay her rent. And if she can't pay her rent, nothing else matters. So it's trying to help people understand this issue. Now, the Affordable Care Act dramatically increased the number of people who were insured. And many of those people who gained insurance through Medicaid. Although I'll remind you that 18 states did not expand Medicaid. And as a result, they created a segment of society who's uninsurable, because those people, those in those states that did not expand Medicaid, they're not eligible for Medicaid, and they don't make enough to go to the exchanges. So those are permanently uninsured. Now I have to say, as the chief medical officer for the Cook County Health and Hospital System, Medicaid, the ACA was a game changer. In 2010, 56% of the people in our beds were unfunded. And believe me, if they were eligible for something, we would have found it. 80% of our outpatients were unfunded. Today, only 42% of all the people we see are unfunded. So it's been a game changer for us. But what that allows us to do is to continue to provide care for those who are not eligible. And what I'm trying to help people understand is who those folks are. Yes, some of them are immigrants. Not all undocumented, because you have to be here 5 years to be eligible. You could be documented, but you haven't had your 5-year period. But there are a lot of working poor who are uninsured. We know that people who have Medicaid are more likely to have visited a physician in the past year, more likely to know that they have a diagnosis of hypertension or diabetes, and more likely to have been treated. That's huge. That's huge. But we know that a lot of people who gain coverage through the ACA gain that coverage with high deductible plans. And I always like to give the example as a Sunday morning, and it was a Sunday morning a couple of years ago, a Sunday morning example of a phone call. Well, it was a series of text messages followed by a phone call with my son, James, who has 2 college degrees, and his big toe. So James, I'm in Canada, by the way, at the time that he's texting me, and he sent me a picture of this big, red, swollen, big toe. I don't know what it is about men and their feet. But I could see that he had a badly infected toe. It's a paronychia, which is an infection from the nail. But I could also see this red streaks going up his feet. Which means this boy has been walking around with his toe for quite a while. And he's now decided he can't get it into a shoe. And can you phone something for me, Mom? No, James, you need to see a doctor. So let me tell you a little bit about James. James was living in Elkhart, Indiana at the time, as the assignment editor for a news station. And he was making all of $35,000 a year for his 2 college degrees. And he had insurance with a $3,500 deductible. And so he wasn't going to a doctor. I'm like, oh yes, you need to go to a doctor. You could order some antibiotics. No, Jane, you need to go to a doctor. I finally prevailed upon him, and he did go to the emergency room. He did receive treatment. He was angry with me for quite a while after that because of the bill that he is still paying off. I will say that fortunately, He's got a better job now. He left that company. He has another curse his mother gave him. He's a White Sox fan, so he's a sports reporter and he covers the White Sox. But he loved it. It's his dream job. He's back in Chicago, which makes me happy. It makes his wife happy, so we're all good. But he's not an exception. So we know that the uninsured and underinsured are more likely to delay care, even for serious events like heart attacks, breast cancer. That people who are insured but the deductible is high are less likely to have preventive services. So I could tell you about a woman who worked as a hairdresser who came to see me, and both her breasts were rock hard with mass. And she was literally sitting at home waiting to die. And her daughter brought her into the emergency room and said, "Can you help her?" The decisions that people make because they can't afford care, and they decide, maybe I can work a little longer, and whether it's worried about burdening their family, or a few bills that they can pay off, or worried about what will happen to others when they're gone and trying to put those things into order. We were actually able to treat this woman. She had very treatable disease. We know that children with higher medication co-payments have poorer outcomes for asthma. And that when we don't treat childhood asthma well, kids miss a lot of school. And that has an impact on what kind of adults they become and how they contribute to society. We know that medical bills are the most common reason for people to receive collection calls. Still. And we know that even with Medicare, medical costs consume more than 20% of the income of seniors who make less than 200% of the federal poverty level. So what's the federal poverty level? People always say, what's that number? It's a moving number. Well, let me just put it to you this way. So if you're a single person, retired, and your income is less than $24,000 a year, or if you're a family of two, and you're making less than $32,480 a year, that is likely your medical costs are 40% of your income, between co-payments and insurance premiums, out-of-pocket expenses. So what is my point here? My point is that people who are poor, people who are immigrants, people who are brown or black, die younger, and they die of preventable, curable disease. They present later with more advanced disease and have poorer outcome because they do not have access to high quality, affordable health care. This is injustice. This is inequality. So I'll say that again. This is injustice and this is inequality. Lack of access to health care drives injustice in this country. We know the zip code matters. If you live in the zip code where this hotel is located, your life expectancy is almost 20 years longer than if you live in the zip code of the south side of Chicago, of Inglewood. Or if you live in the zip code on the west side of Chicago, North Lawndale. So why should that be? Why should that be? Zip code matters. So many of us believe the first step toward equity is to provide everyone with access to health care. You know, I'm not trying to, you know, there's a lot of disparity in this society. I'm just trying to get us to the first step. Just the first step. I'm not trying for world peace. That would be great. I am just trying to help people understand why improved and expanded Medicare for all is the first step in terms of making democracy work. What makes us believe that? How about the disparity in death rates in the elderly melted away when Medicare was passed in 1965? Do you know that? That the death rates, the big difference between death rates between poor blacks and wealthy whites, that disparity began to disappear in 1965. How about blacks in the VA have no disadvantage with regard to their health care, whether you're talking about coronary artery disease, strokes, or total mortality. That when we provide people access, that the disparities begin to disappear. And I would say to you that Americans already pay enough for health care in this country. We just allow too many people who are not involved in the delivery of care to take profit from it. Taxes in the U.S. already pay for 2/3 of the health care spending in this country. We're already paying for it. Medicaid, Medicare, the VA, government employees, health insurance, and I'm a government employee, and the tax subsidies that we give. We spend more than $10,000 per capita. Count the heads. $10,000 per person we're already spending on health care in this country. And yet, we leave more than 1/3 of the population either uninsured or underinsured. We spend $2,000 per capita more than the next closest OECD country. And we like to say we have the best health care in the world. And I always ask, by what standard? By what measure? Our infant mortality rates are higher than the rest of the OECD nations. Our maternal mortality rates, this really, so I've been practicing medicine for over 30 years. And the maternal mortality rate when I started practicing was less than 10 women per 100,000 live births in this country. Do you realize that that number now is over 26? Maternal mortality rates has been increasing in this country, not decreasing, increasing. How can we, as an industrialized country, explain why our maternal mortality rates are going up?
What was the question?
It was, how can we explain, or why do we think maternal mortality rates are going up in this country? And she said, because women are not listened to in this country. It's a huge issue. It's a huge issue, but let me try to get through so that then I'll take more questions. Let me tell you that the Canadians have had national health insurance for 50 years. Their life expectancy is 2 years longer than ours. Their infant mortality rates are 25% less than ours. They see their physicians more often. As a matter of fact, the whole rest of the world sees their physicians more often than we do. Have you tried lately to get an appointment? It's embarrassing to me because when I see a patient and I say, okay, I want to see Mrs. So back in 2 months, and they knock on the door and say, Dr. Fee, you know you don't have any appointments before October. And I say, I'll add a day. I'm going to add a day. I'm going to come in on another morning. The other thing about Canadians, their outcomes are comparable to ours or better, and they have freedom of choice of providers, of the care they receive, who they receive it from, and they spend less than half of what we do on healthcare. We already spend enough on healthcare in this country. The majority of Americans believe that everyone should have access to health care. So why can't we do this? It's so simple. It's logical. Why can't we have universal health care? Single-payer national health insurance. And people say, well, we can't do it. It's just too complicated. So let me remind you that when we enacted Medicare, and this was way before computers, we enrolled everyone in 11 months. If you think the government doesn't know who you are and where you are, and we couldn't enroll you, and then say you would have to opt out, we could do it so quickly. But there are a lot of people who are invested in the status quo. There are 3 healthcare lobbyists for every single member of Congress. This is a huge, huge machine. When someone says we have a healthcare system, I shudder to think that we have a healthcare system. System implies that there's some organization, that there's some connection, and that there's some way to make sure that things that fall through the crack, that we patch things together. We do not have a healthcare delivery system in this country. We don't. But we could. It requires education. Now, this is the sweet spot for the League. The League of Women Voters has spent years educating the public, legislators, providing forums, venues where there can be open dialogue, discussions about important matters for the American public. This is an issue of social justice. And I'm begging you to be engaged in this and help to get us where we need to be. We can provide you Physicians for a National Health Program. We can provide you with the facts, the data, the speakers. We can provide you with the studies, the people who can make this change. But we need you to be in your communities, to talk to your legislators, to talk to the public, to help them understand that we are not going to have an equitable society until we provide access to health care. It's only the first step. But I'm hoping that you're here today means that you're interested, you'll participate, and you want to be a part of a movement to make a difference in this country, to provide social justice, to provide equity. So I'm going to ask you if you'll join me in the struggle for an improved, expanded Medicare for all.